and I try to be as impartial as possible. So, disclosure-wise, I am a registered Democrat, but I worked at some very moderate places in my career. So I worked, does everybody remember the Democratic Leadership Council?
Yes. Yes.
So we had, Al Gore, Bill Clinton when I was there, Joe Lieberman, who is no longer a Democrat. But, it was kind of this moderate wing of the Democratic Party, the New Democrat. We had a magazine. And I worked at the National Governors Association as well when I was in Washington, D.C. And so I think it gave me a kind of unique lens into how we view the policy process. I can actually control it from here. Thanks. And really what ends up happening is, money ends up driving decisions. And you can have the most conservative governor and the lure of Medicaid dollars and the lure of federal funding versus state funding usually ends up trumping the politics of the situation. So we're in this situation right now where, the Affordable Care Act is fairly contentious. It's survived quite a few attacks and it's being implemented, and there are still governors who are going, kicking and screaming, and others who we expected, like Jan Brewer, who's a conservative Republican in Arizona, have decided to take federal dollars and create a Medicaid expansion. And so I think over the next 5 to 10 years, you'll kind of see people pulled along, and states being able to innovate and engage in change related to the Affordable Care Act over time. And so I think it's an important thing to kind of keep an eye on what's going on, and not just assume because somebody falls on a specific side of the aisle that they're going to act a certain way. I think the pull of federal dollars often trumps some of those issues, especially if they're not up for re-election that year. So as Minerva mentioned, I work at the UCLA Center for Health Policy Research. Unfortunately, I'm a bit too young to be the director. I direct a smaller program. Unfortunately, Rick Brown, who Minerva mentioned before, passed away in 2012. But he was kind of a thinker about health policy issues, and he himself was, a champion of single payer until late in his career when he called himself a recovering single payer addict. And so I think, being in the field, he kind of understood the political repercussions and started innovating, started contributing in a different way. So I went to, he's very involved in the Affordable Care Act and the Obama campaign as well. So I try to represent the center as best as possible. And we've been around for about almost 20 years now. Our 20th anniversary is coming up next year, since 1994. So it's kind of fitting that this organization that started when there was no hope of universal health coverage, led by somebody who's fairly visionary in that area, is having its 20th anniversary on the year that a lot of the impacts of the Affordable Care Act will be felt. So as Minerva mentioned, I'm going to go quickly through a set of slides just to kind of give everybody the same framework to understand everything. I know a lot of you have very specific knowledge of different aspects of the law, so I'm hoping you can all share that when we get to the question and answer session. But I'm going to run through the major aspects of it so everybody's kind of on the same page. So the Affordable Care Act, of course, was passed March 23rd, 2010. It was amended through a reconciliation bill that ended up getting signed March 30th, 2010. So we've really been in implementation for the past 3.5 years. And there are lots of things that have changed over time related to the Affordable Care Act, as well as to just the way we're running state Medicaid. You end up with, when the economy is bad and you have a state government that needs funding, you end up with cuts to Medicaid, you end up with switching to managed care, you end up with all these other things that have been going on in our healthcare system that probably would have gone on without the ACA. So it's important to kind of disentangle them, but also understand how they work together a little bit. And really at its core, I think you can think about the ACA trying to impact 3 major issues: access, cost, and quality. And that's usually the triumvirate of healthcare. But it tries to improve access through incentivizing the purchase of health insurance by expanding Medicaid, which is a voluntary process now that the states can engage in because of the fact that the Supreme Court ruled that it was a coercive act to require every state to expand Medicaid. Also increased regulation of insurance products. We have to remember always that insurance is a business regulated by state insurance commissioners, not by the federal government. So despite the ACA's push toward better regulation of insurance products. They basically are relying on state insurance commissioners to execute those mandates and to enable that type of oversight. There's also provisions related to added funding and training for primary care physicians, which has been a constant problem in terms of primary care shortages, especially in underserved areas. On the cost and quality side, a lot of the innovation is occurring through efforts to integrate care better. So you'll often hear about accountable care organizations, bundled payment demonstrations, things coming out of the Medicare program because of the fact that the federal government can't really tell private insurers and private physicians how to operate, but they can influence that market through the Medicare program. So some of you are aware of California's efforts to integrate care for the dually eligible population, those who have both Medicare and Medicaid, through Cal MediConnect, which is a name in California for the coordinated care initiative that was authorized under the Affordable Care Act. So you'll see a lot of kind of CMS-driven advances or attempts at advances around cost and quality related to Medicare and changing reimbursement structure, so moving away from fee-for-service to a more accountable style or integrated style of reimbursement, as well as penalties that are issued by Medicare to hospitals, for example, that have very high readmission rates or hospital-acquired infections, where they're trying to build incentives to reduce hospitals' likelihood of kind of becoming this fee-for-service organization that really churns through services, provides them in quantity rather than quality, and ends up wasting federal tax dollars. So really a lot of the focus will be on access in the discussion today, and I think it's mostly around access in the discussion federally as well or nationally as well, because of the fact that the expansion of Medicaid, the expansion of or creation of health insurance exchanges are these very prominent decisions that will be made by states and will be carried out in 2014, and a lot of the things related to Medicare and Medicaid are kind of hidden behind the scenes, especially as it relates to delivery of care. And from a policy standpoint, probably about half of the Affordable Care Act is really access focused, the other half being split between cost, quality, wellness, other elements. So there are several changes that already went into effect, mostly related to access issues. So one, for example, went into effect 6 months after the law was passed. Children can't be excluded anymore for pre-existing conditions in the individual market. No cost sharing for preventive services in health insurance plans, Medicare, and private plans as well. Adult children are able to add up to age 26 to their parents' plan, whether it's in the employer market or the individual market. About 2.5 million, non-dependent children, but children up to age 26 took advantage of that. We've seen a little bump in insurance coverage due to that policy. What Deborah mentioned before, this ban on rescissions, where previous to the ACA, you had people who, once they used their health insurance coverage, would get their coverage taken away, right? It's called rescission, where somebody uses health insurance coverage and then the insurance company goes and looks for reasons to cancel the policy after they've been paying premiums. So that practice has been banned throughout the nation. There are also state high-risk pools that were developed that are currently ramping down to cover people who had pre-existing conditions, waiting for the exchanges to start in 2014. Medical loss ratio enforcement. It's this idea that insurance companies should spend, I believe it's up here. So if you're in the single coverage market or in the individual market, an insurance company has to spend 80% of their premiums collected on medical care. If they're in the large group market, employer-based market, it's 85-15. So they have to spend 85% of the premiums on medical care. In California, prior to this, it was at about 70%. So this has kind of caused insurance companies to spend more on medical care. Of course, critics say it's going to end up just pushing insurance companies to spend more and more money overall, and premiums will continue to go up. But it's a way of protecting consumers and issuing rebates to make sure that insurers are dedicating more of the premium dollar to medical care. And that happened in 2011 as well. There's also been a lot of effort around oversight of premium increases. So, all of you have seen over the past 3 years these requests coming in from Anthem or Blue Shield to raise premiums on average 19 to 39%, and those typically go straight to the state insurance commissioner and they end there. And now the process is that the insurance commissioner has rate review capacity They have to send anything that's above a double-digit rate increase up to Department of Health and Human Services, and they kind of use that data to engage bad-acting insurance companies to lower rates and put political pressure on. But Dave Jones in the Insurance Commissioner's office is really pushing for what's called rate regulation, which would be a separate state law that would allow him to actually deny rate increases rather than simply look at them, label them as unreasonable, refer them to the federal government, and have no teeth. He's been pretty successful in, railing away at insurance companies, getting them to politically concede to lowering rates, but doesn't have a lot of teeth at the state level. But that's another one of those issues that, even though it's codified in the ACA, it's reliant on state execution. I can guarantee that if Steve Poizner was sitting in that office, you wouldn't have the same type of pressure being put on insurance companies as you do with Dave Jones, who has always championed rate regulation as a way to influence insurance companies. Then some of you may have seen the reduction in the Medicare Part D donut hole, changes in the way Medicare Advantage plans are paid. So there are a lot of changes in Medicare to make it a more efficient program, but also to improve the availability of preventive care and prescription drugs to seniors as well. So those are some of the early issues that have come up in Affordable Care Act implementation over the past 3 years. But I think the biggest changes will be occurring in 2014 and beyond. So I don't know if anybody has ever seen this chart. I like to call it the eligibility staircase. So a lot of people think that Medicaid or Medi-Cal in the state of California is a program for low-income individuals. But in actuality, it's a program for low-income individuals who meet certain criteria, right? So you can't just be a childless adult, male, homeless, under 133% of federal poverty, which is about $15,000 a year, and qualify for Medi-Cal right now. It's a program for seniors and persons with disabilities and parents with children, dependent children. So you can see here that the red and orange are the Medi-Cal guidelines, and the blue is the Healthy Families guidelines. All of these are getting merged into Medi-Cal for kids, but infants, children age 1 to 5, children age 6 to 19 all have different thresholds for when they qualify for Medi-Cal. So you could right now, or a year ago, you could have a parent sign up for insurance who earns exactly 100% of the federal poverty level, $11,000 a year. And their infant that they just gave birth to qualifies for Medi-Cal. Their child age 2 qualifies for Medi-Cal because they would fall right here on the eligibility spectrum. But their 7-year-old would qualify for Healthy Families, and they as the parent wouldn't qualify at all because the adult parent eligibility is at 75% of federal poverty level. So you would have these split families with 2 in Medi-Cal, 1 in Healthy Families, 1 uninsured. And the idea behind the Affordable Care Act is to expand Medicaid, make it simpler so it's no longer an issue of categorical eligibility and income. It's simply an issue of income, and the income level is slightly more generous and more easy to understand. Those of you who are knowledgeable about Medi-Cal also know that these federal poverty level criteria don't just stand on their own. You also have to go through what's called an asset test to show that you don't earn too much, or you don't have too much in resources that disqualifies you for Medi-Cal, and that asset test is going away. So Medi-Cal should become more seamless, and the asset test will go away and easier to understand. So the new modified adjusted gross income based eligibility criteria for Medi-Cal will be 138% of federal poverty level. So that's about $15,500 for a single person, probably about $31,000 a year for a family of 4. So it's still a low income group, but now you end up, if you go back to that first table, you end up kind of making this a red line all the way across, and then adding a whole new category of people, those childless adults who have always been held out of Medi-Cal coverage. In addition, related to access to care, so beyond the Medi-Cal expansion, or Medicaid expansion, offered up by the ACA but not necessarily taken up by the different states, there's also a requirement for large employers to offer affordable health coverage. The idea being that any firm that has more than 50 full-time equivalent employees is subject to penalties if they don't offer affordable coverage, but those penalties are contingent upon the characteristics of their workforce, whether they take tax credits to buy insurance through another source, and some of those elements, which I'll go through in a second. And the third major element is the creation of health insurance exchanges, or health insurance marketplaces as they're calling them now, in Washington, D.C. And so the idea behind these marketplaces is that they would set up a marketplace in each state. So there are 17 independent state marketplaces, 7 that are federally partnered, and the rest are all being run by the federal government, federally facilitated marketplaces. And in this marketplace, basically you can go in and you would be buying guaranteed issue insurance coverage, which means no pre-existing condition can exclude you from coverage. You can't, go without coverage because of any risk behavior, any age group, anything like that. And in addition, if you buy coverage through that marketplace, you could obtain advanced premium tax credits, so tax subsidies to help you afford the premium based on your income. And it's important to remember that not only did it set up these exchanges to enable guaranteed issue insurance coverage and these tax subsidies, but the same exact policies that now govern the individual market health insurance as well as small group insurance, so in California, firms with fewer than 50 employees also have to abide by the same guidelines. So it's not that we're going to have one exchange that's guaranteed issue that you can sign up in, and everybody who's sick will rush there, and everybody who's healthy will stay out. It's that the entire individual market and entire small group market has to abide by those rules. So no insurance company can now say, you don't get in because of a pre-existing condition, or you have diabetes, so we're going to price your premium at $2,000 a month instead of $200 a month. Everybody has to abide by those same rules. So there's no risk of one pool drawing a sicker population over another. In actuality, it's kind of stabilized. But you do have to sign up for the exchange to get those tax credits, which I'll run through in a second. Now, when you have guaranteed issue insurance coverage, you end up with the most politically unpopular part of the law, right? The individual mandate, or what's called the minimum essential coverage requirement. And this is what the Supreme Court was fighting about and determined was constitutional because it's a tax and is within Congress's taxing authority. Because the concern relates to people who don't buy coverage in a guaranteed issue insurance market, right? If you don't buy coverage in a guaranteed issue market, you can show up anytime you want and end up signing up for coverage. And even if you have a significant healthcare issue, you just got a cancer diagnosis, all of a sudden you can just go into the insurance company, pay a premium, and all of a sudden get healthcare, and that's going to drive up costs for everyone else. So the idea was to expand the pool of people in these individual market insurance products so that insurance companies are willing to take that risk, jump into that market, and then you have people using their tax subsidies to help them buy that insurance coverage through private insurers and some kind of quasi-public options. So to avoid that issue of adverse selection, that issue of free riders, what happens is penalties are going to be phased in on tax returns starting in 2015. So April 15th of 2015, people will be paying retrospective penalties on their insurance status during the year of 2014. So if you don't carry creditable insurance coverage during 2014, you would be subject to either a $95 per person penalty in your household at a maximum of 3 people, so $285, or 1% of your household income on your tax return at the end of the year. So it's not that, in 2014, if you don't sign up, you get a bill in the mail for $285. You basically are given the entire year to sign up. There are certain exemptions that are allowed, and at the end, when you're reconciling your taxes, if you didn't sign up, you may pay a penalty. A lot of people probably won't notice this because I think about 50% of the population gets some sort of refund at the end of the year. So it's not going to be kind of a light bulb that goes off, oh, I should go buy insurance because I paid this penalty. Their accountant's just going to say instead of a $3,000 tax refund, you got a $2,700 tax refund, and people may not notice all that much. Those penalties are phased in over time until 2016 when they are maximized, and then they'll be increased by cost of living after that. So in 2016, the penalty goes up to $695 per person, so maximum of $2,085 for a family, or 2.5% of their household income. So if you're higher income, you have to pay that higher 2.5% income penalty. There are quite a few exceptions though. So if you have a religious exemption, so you're like a Christian Scientist or something like that, where you don't actually use healthcare, you could opt out. If you join one of the kind of cooperative religious organizations that run their own healthcare benefit, you can opt out of the expansion or of the requirement. If you're a member of a federally recognized Indian tribe, If you're uninsured for less than 3 months, you don't have to pay the penalty. If you have a financial hardship and the cost of coverage would be more than 8% of your income, you can opt out. And if you're low income and below the tax filing threshold of $9,750 for an individual, you never file taxes, so there's no ability to charge you that penalty. So anyone who meets any of those exceptions is basically ruled out of the mandate. So really, you're only dealing with about 50-60% of the future uninsured population that would be subject to that mandate penalty in the first place. But in addition to the guaranteed issue and the individual mandate, there are some other protections for consumers. One is that, and most of them are delivered through Covered California, but as I mentioned, they extend beyond Covered California as the health insurance marketplace to the entire individual and small group market. Everybody has to kind of play by the rules in that market. If you're in a firm with more than 50 employees with employer-based coverage, things are basically status quo from a insurance rating perspective, from a premium perspective, because they can still use the experience of the workers to determine the premium. So if you work in a firm filled with coal miners and you're the one dispatcher and you're perfectly healthy, but your 10 colleagues are, your 100 colleagues are all at higher risk, your premiums will probably be higher than somebody working in an office with a less risky population. So experience rating, that idea of using healthcare costs and risk factors to price a premium, is still alive and well in the employer market if you have more than 50 employees, and in 2016 if you have more than 100 employees. Right now though, if you have less than 50 employees, your firm has to move to what's called basically modified community rating, away from experience rating, and the premium can only be based on 3 different factors. So those 3 factors in California will be age, location, and policy type. So there's a 3-to-1 rating band for age groups. So if you're an 18-year-old, you can be charged $1, and the 64-year-old who buys the exact same plan could be charged $3. But that's the cap at which there could be rating variation among premiums. Right now, we usually see a 10-to-1 rating variation on age. It'll be shifted down to a 3-to-1 rating variation. Location and policy size, so there are 19 different rating regions in the state of California. So LA has 2, I believe Lancaster, Palmdale get 1, everybody else gets another. Riverside and San Bernardino have their own. So there's 19 different regions that were split out, and so Southern California premiums will be lower by 1.5 than Northern California premiums, because there's a 1.5 to 1 rating variation allowed on location. So Northern California premiums could be 50% higher than Southern California if an insurance company so determined. And then policy size, of course. So are you signing up for single coverage? Are you signing up for couples coverage? Single parent with 2 kids, 2 parents, 2 or more kids. So they're basically just kind of 4 different policy types that you would fit into, and there could be a 1.5 to 1 variation on those as well. So really, if you put all those together, you're looking at maybe a 6.5 to 1 rating variation, where even the single healthiest, youngest person in a market could be charged $1, and the oldest one with the largest family living in the highest cost area will be charged $6.50 for the same policy. So it tightens the rating scheme a bit. The other issue that kind of protects consumers is this issue of essential health benefits. So as mentioned before, the mental health parity has been a big issue because of the fact that employer plans have always had to abide, or since 1996 have had to abide by mental health parity, but individual market plans haven't had to. So they don't have to provide the same level of coverage on the mental health side as they do on the medical side. And that changes with what's called the essential health benefits package. So each state is asked to default to a federal option or pick their own employer-based plan to serve as a target for the essential health benefits that will be covered by every single individual market plan and small group plan that operates in the state. And that includes prescription drugs, it includes maternity child benefit, it includes oral and vision care for pediatrics only, it includes mental health services. So whereas right now, if you went on ehealthinsurance.com and tried to find a plan, you'd find something with a $10,000 deductible that said no prescription drug benefit, no maternity benefit, and no mental health benefit. So you're buying this cheap plan, but it has fewer benefits than a typical person would get through an employer. And that will change with these 10 essential health benefits. So it could mean that people in these really inexpensive plans will see their premium go up, because of the fact that they now get a more generous benefit package that is required by state law. So the standardization of benefits and value and kind of this transparency in pricing will be really important to making sure the individual market is sustainable over time. So I apologize, this table's a little bit difficult, but I just created it today because I thought it might be helpful to kind of think through how these tax credit subsidies work. So these premium tax credits are available to people who sign up in the individual market through Covered California, our insurance marketplace. And depending on how much money you make, your premiums are capped at a certain amount of your income. And that ranges from 2% all the way up to 9.5%. So if you're a person coming into the exchange with earning 100% of federal poverty level, or let's say 200% of federal poverty level, for a family of 4, your earnings are $34,575, and your premium will be capped at 4% of that income. So it basically is providing a ceiling. So when you see these premium subsidy levels, it doesn't mean that you're expected to pay 4% of the cost of your premium or anything like that. It means that they're going to look at your premium and look at what 4% of your income is and pay the difference, right? So you're going to get this advanced premium tax credit when you sign up for coverage in the individual market based on your income. So this gives you a sense of what it looks like for a family of 4. So if you're earning $31,809 as a family of 4, you're under 138% of federal poverty level. So you're allowed to go into Medi-Cal completely free, right? You end up with the same benefit package and no co-payments, no premiums, no deductibles, and you get this free coverage. Now, if you decided, I don't want Medi-Cal, I would rather buy my own private insurance, you're allowed to. You just have to pay the full price, right? So the full price for somebody with a 4-person family signing up for the Anthem HMO Silver Plan coverage would be $793 a month, which is actually fairly affordable compared to what we see now. Or you decide, I'm going to go into Medi-Cal, right? And this is modeled on a family of 4 with a father who's 42, mother of 40, and a son and daughter of 16 and 15 years old. Now, if you step up in terms of income up to $34,575, that's at 200% of federal poverty level. So that's at a pretty sweet spot in terms of how much subsidies you would get from the federal government to help you buy your policy, because your premium is capped at 4% share. So in this case, your kids, because they earn under 250, you're earning under 250% of federal poverty level, actually qualify for Medi-Cal under the Old Healthy Families Program. So your kids could be in Medi-Cal completely free, and you and the spouse can go buy private insurance. So your $533 premium, because it's for that couple, would be offset by $423 in tax credits, which is basically equal to the monthly, it's the difference between spending 4% of your income out of pocket and the premium cost. So your final monthly premium will only be $110. And you can see as you go up the income spectrum, the share of premium passed on to the family gets higher and higher as they share of the total premium. So the premium stays the same. From once you get above 250% of FPL, your kids are no longer covered by Medi-Cal. They end up getting added back to the private plan, and so the premium is $793. But if you're earning roughly 300% of federal poverty level, or $69,150 for a family of 4, you get a $256 per month tax credit, and your final premium is $537. So you can see that basically from low to middle income, the insurance product you can afford becomes a little better as time goes, as you go up the income scale than what you would have paid out of pocket on your own. Now, but the biggest subsidies are really concentrated at people earning between 139% of federal poverty level and 250% of federal poverty level. So this kind of $32,000 up to $60,000 middle class group, whereas the subsidies are less concentrated at the higher income groups. The other thing that happens is that basically the exchange says, okay, we're going to peg your subsidy, your tax credit, to what's called the silver plan, which is the 70% actuarial value plan, meaning it's basically a $2,000 deductible and probably like $45 co-pays for basic services. But there's a cap on out-of-pocket cost of around $6,300, and so it's still a fairly generous insurance product compared to what you currently see in the individual market. So you can use that subsidy to buy whatever type of plan you want, but they cap it at the silver level. So you can use it to buy a gold platinum plan that has no deductible, but you're paying a larger share. Or you can decide, I'm going to buy a $5,000 deductible bronze plan, and I'm going to basically have a free premium, but I'm going to take on a lot of risk as a consumer because of the high deductible. So in this case, I'm pegging the silver plan as that 70% actuarial value, but if you're lower income, the federal government automatically upgrades your coverage by capping your out-of-pocket costs. So this $110 premium is actually buying what's equivalent to a platinum plan. It upgrades your silver 70% plan up to a 94% plan. If you're at 250% of FPL, it upgrades your 70% plan up to a 73% plan. So there's this cost-sharing subsidy that runs in parallel to this tax credit subsidy at the same time to make it more affordable for people of lower incomes. So that's the individual market, right? So people will be able to go shop for coverage on Covered California. If you go on right now, coveredca.com, you can basically enter your age, family size, where you live, and you'll see premiums pop up, and then you'll see this is how much tax credit you can claim, and this is what your effective premium will be. And you can choose from HealthNet, Anthem Blue Cross, a.k.a. Molina, I think 8 different plans in LA area. Now, on the employer side, there's this concern that employers are just going to drop coverage and stop offering coverage to their employees. And so there are penalties that are called the employer responsibility or employer shared responsibility requirements that would mitigate that effect. Now, they have been delayed until 2015, but they would go into effect in 2015, and the penalties would be either $2,000 or $3,000 per employee, depending on the characteristics of the firm. Now, if you're a firm that has fewer than 50 full-time equivalents, where full-time equivalent is a 30-hour-a-week worker, so if you have 100 30-hour-a-week workers, then you have 100 FTEs. If you have 120-hour-a-week workers, you basically have 66 FTEs, and you still qualify for that requirement. However, once you hit that 50-plus full-time worker construct and are triggered as somebody that could pay the penalty as a firm, then the number of full-time workers you employ starts mattering. So if you're a completely part-time firm with more than 50 part-time employees, even if you hit that 50 full-time equivalent trigger, because of the fact that you add up all the hours of your full-time employees and it surpasses the trigger, you may still not be eligible for paying any penalties because of the fact that none of your workers work more than 30 hours a week or work under 30 hours a week. So you can see here where you can have a 49 FTE firm that has everybody working full-time, 49 workers, 20 of them take a Covered California tax credit, the rest either stay uninsured or decide to buy a plan offered by the employer, and they're not subject to any penalty there because they have fewer than 50 full-time equivalent employees, and regardless of what those employees do and what the firm does, it doesn't matter. They're not going to be charged a penalty. So this is comforting to a lot of small business folks because of the fact that 96% of our firms out there are under 50 employees and are viewed as small group market, and they don't have any requirement to adopt coverage and start offering it. So there shouldn't be any fear out there about smaller firms having to start offering coverage that they didn't before. They of course still have the option of offering coverage if they want to their employees and taking a tax credit and taking the tax deduction from payroll tax, but they don't have to do anything. So then I have these two scenarios here where you actually have a firm that should be paying penalties because they have more than 50 FTEs and they have some full-time employees. And I have two scenarios. One is the offering scenario, and one was a firm that doesn't offer. So if a firm offers coverage, they have to do what's called offering minimum value coverage. They have to cover at least 60% of the value of the healthcare on average out of the premiums. So if they offer that minimum value coverage and it's affordable, so it's a single premium is less than 9.5% of household income, then they wouldn't have to pay the penalty at all as long as they offered that affordable coverage. However, if they offered coverage but it wasn't affordable or didn't meet minimum value standard, then they would be paying a penalty based on the number of employees in that firm that took a premium tax credit through Covered California. So it's not that they get fined based on all of the workers in the firm, it's that they get fined based on the number of people actually going and taking that tax credit because they offered some coverage even though it was unaffordable or didn't meet the minimum standard. So in this case, I have the scenario where 20 of them go take coverage in Covered California, take a tax credit subsidy, and that triggers a $3,000 per person per year penalty for just those 20. So the firm pays $60,000 versus if they don't offer coverage at all, the same exact firm would only pay $38,000 because of the fact that when people going in to use the tax credit would trigger a penalty for the firm, but if you don't offer any coverage at all, you are only subject to penalties on your number of full-time employees minus 30 times a $2,000 penalty. So in this case, the non-offering firm would be paying this $38,000 penalty and their workers would be going into the exchange. Now in this case, if they're not offering, odds are the number of full-time workers going in to take the subsidy would be much higher, so they would actually pay a much larger penalty because of the fact that they're paying for every single worker in the firm who they're not offering coverage to, even though they don't take the subsidy. So, how will California look in 2019? So at UCLA and UC Berkeley, we have what's called CalSIM, the California Simulation of Insurance Markets Model. And it's a lot of data sets that we make talk to each other. And we've been working on it for about 4 or 5 years now. But we're predicting that about 1 to 1.4 million people will enroll in Medi-Cal by 2019. So there will be kind of a ramp-up period, but eventually about 1.4 million extra people will sign up for Medi-Cal because they meet the new eligibility criteria. And some are people who are eligible now and just haven't signed up. And then we expect about 1.7 to 2.1 million people to go into that health insurance marketplace, Covered California, and actually use subsidies to buy coverage. There's still another 2 million people out there who might be in the individual market now, who might be uninsured, who are likely to buy coverage in the individual market, whether or not it's Covered California, because of the fact that they're over 400% of federal poverty level, wouldn't get any subsidies, but they find it more attractive to be there than in the current individual market or uninsured because of the penalty. So that was access. So there's some other aspects of the law that relate to cost and quality, and I'll run through them fairly quickly so we can get to questions. And as I mentioned, Medicare and Medicaid are attempting to innovate in reducing cost and improving quality through demonstration projects and pilots. So there's several things rolling out. So I mentioned before the dual eligible demonstration, that's one example. But where we're seeing a lot of movement now is in what's called accountable care organizations, where about 250 or more healthcare organizations have kind of banded together in different networks to try to create more of an integrated style of doing things, and they're willing to accept risk from the Centers for Medicare and Medicaid Services to meet certain quality metrics and also save money. And if they are able to undershoot the projected cost for them that Medicare determines, they're able to keep part of that profit. So you can envision that Cedars-Sinai, let's say, would, Medicare would say, okay, you want to be an accountable care organization for us. We think next year you would have spent $1,200. However, if you save if you come in at a price that's lower than $1,200, we can potentially share those savings with you. So let's say Cedar spends $1,000 per Medicare beneficiary next year. Then there's $200 left that CMS expected to spend but didn't spend, and they would then split the difference with Cedars-Sinai. So Cedars might get 50% of that bonus depending on how well they did on patient satisfaction scores and process measures related to diabetes care, hypertension, etc. So there's a quality component and a cost component designed to kind of trigger an intervention that will result in both reduced costs and improved quality. Now, one of the key things of an ACO model, this accountable care organization, it's supposed to kind of be like a virtual managed care organization, right? We know Kaiser does fairly well from a integration, communication, satisfaction, and quality perspective, but we have a very hard time getting other providers to work in that model, right? They don't play well in the same sandbox, they don't refer to each other, they don't all adopt the same electronic medical record, and this is an incentive that CMS is trying to see if they can get providers to do a better job of integrating. Also, there's an innovation center within the Centers for Medicare and Medicaid Services that's requesting that basically proposals that will allow healthcare providers to get up to $30 million a year to innovate. And so different organizations have gotten grant money through these innovation grants to reduce fall risk, to reduce healthcare acquired infections, to reduce readmissions, to improve coordination of mental health care. So there are lots of different pilot projects going around throughout the country with that are supposed to try to establish new evidence and best practices around caring for the Medicare and Medicaid population that both save money and improve quality and integrate care. So there's a lot of kind of innovative stuff going on behind the scenes. Another element you've probably heard a lot about is the Independent Payment Advisory Board, which is very cost-focused. It's what Paul Ryan likes to call a death panel now that the other death panel got removed from the law. And what IPAB does is it's this group of 15 appointed officials that are required on a yearly basis to assess how much Medicare costs are going up or down. And if the Medicare spending that year exceeds gross domestic product plus 1%, they're required to write a report to Congress that says, this is how you get back under that target. So if GDP plus 1% is 4.5% one year, and Medicare is going up at a 5% rate, then this advisory board has to figure out a way to cut 0.6% from the Medicare budget and send that report to Congress, and Congress has two options, which are very difficult to do sometimes. One is to act on it and pass a law. The second is not to fail to pass a law, but just accept the report as is and integrate, and actually allow CMS to implement those cuts. Now, the thing with IPAB though is that this board is explicitly forbidden from making changes to eligibility, to benefits, but they only have purview over spending, or over actual reimbursement. So they have two options. They can cut rates to Medicare Advantage plans, or they can cut rates to providers, and that's all they can send to Congress. Now, similar to the sequester, right, the idea was we're going to threaten Congress into acting, but if they do nothing, at least it goes into effect. So there's still a way to balance, kind of make Medicare solvent over the years with the Independent Payment Advisory Board, because coming from this third party, but it's very unlikely that Congress will typically act and replace it with anything of meaning. There's also other innovation projects going around related to bundling payment for long-term care and acute hospital discharges, and using global payments to safety net hospitals. So there are lots of experiments going on in Medicare in states and in providers that have kind of opted in and asked to partner with Medicare to try to improve things. On the payment reform side with Medicare, there were pay-for-performance incentives added to Medicare Advantage. So if you're a Medicare Advantage plan that rates 4 or better stars, you get bonuses due to those quality ratings and patient satisfaction ratings that didn't exist prior to the ACA. And then two of the big elements are related to hospital-acquired infections being not reimbursed by Medicaid programs in states, and also if hospitals have a very high readmission rate, they get dinged by about 1 to 3% depending on the year, because as kind of punishment for having those high 30-day readmission rates that are preventable. And there are also some elements around coordinating care within our healthcare system. So this goes beyond just Medicare and Medicaid at this point. There's a pretty large investment through the Public Health and Prevention Trust Fund, as well as National Health Service Corps and Federally Qualified Health Center funding to improve team-based care, use more nurse practitioners and PAs in a patient-centered medical home model to really intervene with chronically ill individuals and mentally ill individuals. And then, of course, the Cal MediConnect program, this coordinated care initiatives for the dually eligible population, where typically you have Medicare fee-for-service and Medicaid fee-for-service running in parallel, nobody talking to each other, everybody billing for as much as possible. Then we move to this world of either Medicaid managed care or Medicare managed care plan is doing a lot of the work, and there's still fee-for-service going on the side, and now we're trying to move to this world of 2 managed care plans or 1 managed care plan getting assigned to Medicare patient and being required to meet certain performance goals, actually talk to each other, use common data elements, etc. So LA Care is the big Cal MediConnect provider in the LA County area. So, as you can see, the law is pretty all-encompassing from a cost, quality, and access standpoint, but there's still elements that are appropriated or that are authorized in the law but not appropriated. So there's certain aspects where the federal budget allotment hasn't been made to fund different aspects, and I really didn't cover those today, but one example is the Class Act, for example, which was community-supported long-term care, where workers would be contributing to this fund and they would be able to get a cash benefit to pay for long-term care supports after they needed long-term care services, and that aspect wasn't implemented by HHS and then was defunded in a budget compromise later on. So there are lots of different elements of the law that have been tweaked a little bit due to the budget process. So there are elements of the law that people weren't paying much attention to or weren't getting implemented that got taken out, but there arguably, and I can talk about this during Q&A, certain aspects of the law that were actually harmed by the fact that, you know, Republicans were driving a hard bargain related to taking certain things out of the ACA, and some of it may have undermined the, you know, competition and ability for people to use tax subsidies in the exchange, and so there's concerns about that as well. But really, you know, the name of the game for the next month is going to be whether Republicans decide to sit on the budget appropriation for next year to try to cripple the ability of ACA going into the field October 1 for open enrollment and January 1st for actual coverage. Because repeal isn't politically feasible, but budget debate is. So I think the things to keep in mind are implementation will vary a lot by state. We happen to live in a state that decided to do a Medi-Cal expansion, decided to keep the same Medi-Cal benefit package that's available now and use it for the newly eligible population. One that has created a pretty robust covered California exchange that's run by the state through establishment grants by the federal government that's fairly innovative. Whereas other states have no Medicaid expansion because it's voluntary, and they have a federally facilitated exchange that may not really meet the needs of the state population because the federal government has to run, you know, 20 plus of them. So I think you'll see lots of variation over the years as states implement, and really it's the red states that will suffer because of the fact that they'll still have high uninsurance rates, and they tend to be the places with the highest uninsurance rates already. So Arkansas, Texas, etc., if they don't jump on board the bandwagon, then unfortunately their lower income population will suffer. Because one of the interesting things that the ACA does is it basically says that anybody under 100% of federal poverty level, like the really hardcore Medi-Cal eligible population, very low income, cannot qualify for those federally funded tax credits. So Texas can't just say, oh, we're not going to expand Medicaid, everybody's going to go into this federally facilitated exchange. It's better for us because it's all federal dollars and they get a private plan. Those really low income people are actually held out because they can't be in Medicaid and they can't be in the exchange. So how that works out will be interesting. Arkansas is actually pursuing an alternative method where they would roll all their Medi-Cal population into the exchange and come to some agreement with the federal government that it's worth the Fed's money instead of expanding Medi-Cal or Medicaid. And there's some other important aspects. One is that in 2017 and beyond, and Vermont is already pursuing this, states can basically apply for a waiver from the federal government and say, well, we can guarantee a certain level of access. So right now we have 95% of our insured population, or of our uninsured population covered, and we've succeeded in ACA implementation. If the state decides, as long as they can guarantee that they would continue that level of insurance coverage and it wouldn't compromise quality, access, or cost for their population, they could decide to use a new method of insurance coverage. They could go away from Medicaid expansion, they could go away from exchange, they could create a single payer program, they could do, you know, an exchange for everybody, including Medicare, Medicaid, and private insurance. So there's quite a bit of opportunity for states to innovate, and states will be asked to use this federal money to design a program that meets their needs versus just having to fit into the mold that the ACA laid out. Of course, with federal oversight and renewal and oversight of those waivers. But some of the other important things to think about are this issue of workforce expansion. Do we have enough doctors to take care of the newly insured population? Are they in specialties we need? Are they located in the areas we need? You know, Central Valley has very high uninsurance rates and very few providers. What happens if you add people? Cultural competency and outreach. A lot of the uninsured and eligible population will be Latino, Spanish speaking, and may not value or have knowledge of how the subsidies will work or how Medi-Cal will work and that type of thing. Another element is the contracted health plans in covered California. They're going to change on a yearly basis, and the offerings and networks in those plans will change. I believe there's an LA Times article about the fact that the way we had such low premiums in covered California was because covered California is driving this very hard bargain on premiums with the companies that wanted to sign up. So UCLA is in the Anthem policy, but not in the a.k.a. policy, not in the Health Net policy. So it looks very much like the employer-based market, where we've seen these shifts over time in providers in contracts, and health plans, of course, have been trying to use their leverage to get providers to take lower reimbursement than maybe they're used to. Medi-Cal payment rates will be an important aspect. As we talked about before, they're lower than the national average. Also, there's a pretty significant part of the law that thinks about, if you have all these uninsured people who are getting coverage, we need to reduce the spending on safety net programs that are built for the uninsured. So if the uninsured are going away and they're being replaced by paying customers, why are we dumping a bunch of money into safety net hospitals like LA County? And so there's this kind of crunch that will occur where county hospital funding is coming down while insurance is slowly going up, and we have to make sure that it kind of meets in the middle, and that the revenue that was coming in from federal subsidies to cover the uncompensated care they were getting is now being replaced by private revenue coming into the system. So I will leave it at that. I'm happy to take questions. If you have more questions about details, these are 3 very good websites to go to. There's a longer 2-hour webinar that we did on the ACA. I could send you the link to that as well. So happy to take your questions.